Welcome to today's webinar entitled Surmounting Stigma in Mental Health. I'm going to turn it over to our moderator. Jerry, you're on now, please.
Thank you. Hello, everyone. It's my pleasure to welcome you to this national webinar on stigma and mental health, sponsored by the CASN Mental Health Educator Interest Group. My name is Jerry Lasiuk. I'm the chair of the Mental Health Educator Interest Group and an associate professor at the University of Saskatchewan. Also helping out today as host is Jane Karpa. Jane is an associate professor in the Faculty of Health Sciences Psychiatric Nursing Program at the University of Brandon. And we also have with us three speakers today, Romy Christie, Tanya Kondo, and Judeline Innocent. I will be telling you a little bit more about them as I introduce them before their presentation. So I'm very pleased to tell you that the webinar is fully subscribed, which suggests to me that nurse educators across the country recognize the importance of health, mental health, and stigma. As I said, we have participants across the country, and it will be interesting for us to have an opportunity to perhaps compare experiences during our question and answer period. I would also like to acknowledge my special guest today, the Nursing 307 class from the University of Saskatchewan, Regina, and Yorkton campuses. As most of you know, CASN is the voice for nursing education here in Canada. And its members are from universities and colleges across the country that offer part or all of an undergraduate or graduate degree in nursing. CASN's primary objective is to lead nursing education and nursing scholarship in the interest of healthier Canadians. It does this in part through nurse educator interest groups and by providing national forums for issues in nursing education and research. If you aren't already a member, I encourage you to join the CASN Mental Health Interest Group. We have at least 3 virtual meetings during each year, during which we discuss topics related to quality nursing education and mental health. And you have some information here up on the screen about how you might join. So before we hear from our speakers, I would like to tell you that you can submit questions to the speakers using the Q&A pod, and your names will be withheld, so you can submit these questions anonymously, and the host will then redirect them to the presenter. Each of the speakers will present for about 10 or 12 minutes and then respond to questions from participants. So this is our agenda for the day, or for the next hour or so. And I'm going to begin now by introducing our first speaker, Romy Christie. Romy joined the Mental Health Commission of Canada in 2008 as one of its first employees. Since then, she has been instrumental in Opening Minds, the largest systematic effort in Canadian history focused on reducing stigma related to mental illness. In 2015, Opening Minds received the Most Innovative Program Award at the International Stigma Conference in San Francisco. So just to tell you a little bit more about Romy, before her work with the Commission, she worked as a current affairs producer with CBC Radio in Calgary. Romy has a BA in English and Psychology from Queen's University, and she also studied journalism at Carleton University in Ottawa. So Romy will start off today by presenting resources and research done by the Mental Health Commission related to stigma. Romy.
Thanks so much, Jerry. And thank you as well, CASN, for bringing this webinar to a broader audience. This is a really important topic that the Commission really cares about, so we really appreciate the opportunity to speak today. Can you advance, please, Sharada? So I wanted to talk a little bit briefly about why the Commission is working to reduce stigma. And I know Judeline is going to be telling you a little bit more about this in her segment, but stigma is one of the major barriers preventing people from seeking help, and so it's really important that we do something. And many people living with a mental illness say that it's harder to live with stigma than it is to live with the illness itself. Could you advance, please? So Opening Minds is the anti-stigma initiative of the Commission, and we've taken a targeted approach. We've done something different than what's being done around the world where a lot of mass media campaigns took place. The literature, as we were starting, showed that to take a targeted approach could be more effective. So we started out with youth, healthcare providers, the workforce, and news media. And we chose not to reinvent the wheel and create programs on our own, but to try and build on strengths of existing programs that already existed in Canada. And we assumed the role of doing evaluations of programs because we discovered that many of them had not been evaluated to really show if they reduce stigma. So we've been working with research teams. They've created different survey tools for the different audiences, and the one for healthcare providers is something that we've used for the healthcare provider programs. And we've created, therefore, an evidence-based approach, and we've identified successful programs that can be adopted anywhere in Canada, and the key ingredients that many of those programs have. And one of the key ingredients I just want to mention is something called contact-based education, where we hear from people with their own lived experience of mental illness telling their personal stories. And we're going to hear a demonstration of that very shortly from Tanya. So we're fortunate to have Tanya joining us today. Can you advance, please? So tackling the roots of stigma, I want to let you know that we make the assumption that all of healthcare providers enter their professions to help patients. They want to make a positive difference. And so in our research, we looked for, well, what are the learning needs related to stigma? If patients are experiencing stigma, what are the learning needs among healthcare providers? And the first one is a pessimism about recovery, that many healthcare providers don't believe that what they would do would make any difference. And Sharada, can you please put that poll question forward to the people who are participating today? And you'll have to jump in when you see the results rolling in because I can't see the results myself. But I'm curious to know, do you think that that recovery is possible, and have you seen that other healthcare providers have believed or not believed in recovery? So I don't have the exact wording of the question. It's on the screen. And they also, healthcare providers, have a lack of skills and confidence. And there is a lack of awareness of their own prejudices, and they see the illness before the person. So all of these are pretty important. So Sharada, can you advance and have the results come in yet?
Yeah, we see about 60% of the people are not surprised. So we have, are you surprised healthcare providers don't believe recovery is possible? And we have 60% saying no and 40% saying yes. So 40% are surprised.
Okay, 40% are. Well, you know, we were really surprised at the Commission early on, and we tried to figure out, well, why is that? And on the next slide, please, Sharada, which is the quotes. I can't remember if I asked you to go to them, but that first one says in the quote, many don't realize or don't really see recovery as possible because they don't know what it looks like. Because when they see people coming to them for help, they're at their height of distress, and they don't see people when they're recovering. And certainly you can imagine that's the case. When people are recovered, where are they? Well, they're back at work, they're looking after their families, they're getting on with their lives. They're not coming back to the doctor's office anymore or going to the emergency room where so many nurses see them. And so there's also this lack of knowledge among healthcare providers we see in that second quote, saying that they simply don't know what to do and what to say. So those are two key areas that we've been working on. Can you advance, please, Sharada? So we have, in the programs that we've evaluated, about 25 of them, they're for three distinct audiences within the healthcare provider audience group. The first one is university student programs. The second, professional colleges and associations of nursing and physicians and whatever. And the third are the working healthcare providers in ERs and other departments in hospitals or emergency rooms. And we've got some really great programs that we've evaluated that can be rolled out to all of those audiences that I want to quickly go through. Sharada, can you give me a bit of my time right now? Where am I on time?
You're at your halfway mark.
Okay, perfect. That's where I wanted to be. So the Intensive Social Contact Partnership module was created through the University of Brandon Psych Nursing Program. If you haven't advanced to that slide, can you do so, Sharada, please? This is a program that was created to fit into a full semester program, and it's really a module within the course. And Jane Carpa, one of the co-facilitators, she was one of the creators of that program, and we were very fortunate to have that program brought to light early on. We did an evaluation, and you can see how well they did. In that, I mentioned that we created a survey to determine how well healthcare providers did in the pre-test and post-test on that survey. And we did the evaluation to figure out, in those charts show, or the chart shows, how well they did, 80%. How many of them would have got 80% on the survey? And in the pretest, it was at 41%. And at the end of that semester, it was up to 72%. And just quickly, I'll tell you a little bit about the program. A student is paired with a person with lived experience who tells their story through the course of many meetings with that student. What's it like to live with a mental illness? What kind of stigma have they experienced? How does a mental illness affect their lives? And so at the end of that semester, the student has to turn in an assignment, and the patient or the person with lived experience, that person helps evaluate the paper, the narrative. It's called a recovery narrative paper, and they help the professor do an evaluation to see how well they did. So please advance, Sharada. This slide shows how well a program that is a workshop program, anywhere from an hour to an hour and a half to 2 hours in length, that can be delivered within a hospital for ER workers and whatever, and how well it did. And it is primarily to reduce stigma. And at the beginning, the pretest, and this is when it was delivered to the IWK hospital in Halifax. At the pretest, they were at 38% getting that A grade, and at the end of the course, it was 61%, so they did really well as well. And please advance to the next one. Among the professional association programs, we have helped to and partnered with organizations to create a couple of online courses, one that is for physicians and one for nurses. We are in the process of doing the evaluation on the nursing program right now, but this chart shows how well the physician program has done, and the nursing one is based on this, so we're hopeful that it will show similar kinds of results. At the pretest, again, 42% of doctors would have got an A grade, and at the end it has risen to, I think that says 73%. It's very small on my screen. But it did really well, and there are lots of clips hearing from both physicians and and other healthcare providers, nurses in ERs and whatever, talking about stigma, as well as people with lived experience talking about what kind of stigma they experience. And then this next slide, please, Sharada. It is showing the practice support program that was created in British Columbia for physicians. It's 3 half days and has shown phenomenal success in both reducing stigma and increasing physician confidence and their skill level. And we did a randomized control trial in Nova Scotia recently that shows also very promising results. You'll see some of the promising results in that first side of the chart shows the confidence level of physicians at the pre-test or at the beginning of the program, then at the end of the program, and the third column there is at the end of 6 months. So it shows that their confidence levels keep on increasing, and the control group is in that next part of the chart. So you see that they were really they just were the same at the pre-test.
Just a 2-minute warning, Romy.
Okay, perfect. Thank you, Sharada. And so the really good news as well is that at the 6-month follow-up, we've done some really good evaluation work with the patients, and the early results are showing that at the 6-month point, there's a marked decrease in the number of patients who are using antidepressants. And at that 6-month point, the patients among the control group, they're really edging up on both the use of antidepressants and also not feeling very good. Not on the scale of, I can't remember what the test is called that they use, but they're not doing as well within themselves as well. So we are really excited about that program. There's a portion of that program as well called CBiz that can be and is often delivered to other healthcare providers, and that's a one-time thing of 2 to 2.5 hours for them to receive training. So next slide, please. So at this point, we are really keen to take the findings of our research and take the programs as much as possible into the limelight so that they can be shared across the country. The psych nursing program, for example, the two profs, Jane Carpa and Renee Robinson, they are more than willing to hold a webinar for nursing schools around the country or other healthcare programs like med schools or OTs or whatever. And the same holds true for the professional association programs, that practice support program, as well as the online CME and the continuing professional development program for nurses that's online. And for the hospital programs, there's the Understanding Stigma program that I showed you the slide of, and there are other ones as well. And what we also find is that if there is follow-up, if there's a one-time program, that sometimes once stigma is reduced, then it can begin to creep up again. So we know booster sessions are also really important, and we've got lots of programs, booster session material as well. So last slide there, Sharada, I am more than happy to answer any questions, or if we want to hold questions to the end, I'm not sure.
Yeah, I think we'll hold questions to the end.
Great.
Thank you so much, Romy.
You're welcome.
So it is my pleasure now to introduce you all to Tanya Kondo. Tanya is a mental health care consumer, and she's going to speak today from the heart on the stigma she has faced. Stigma is the Partnership Program Coordinator for the Schizophrenia Society of Saskatchewan here in Regina, where she helps consumers, families, and mental health professionals develop their stories of hope and recovery. She also presents her own story, as she will do today, to share at Anti-Stigma Talks. So Tanya will be presenting from the consumer perspective and discussing issues about what it's like to live and work with stigma. Tanya.
Thank you for inviting me to talk today. As mentioned, I use my lived experience to help other people with lived experience, family members, and mental health professionals develop their stories of recovery and hope. We bring these stories into the community in contact-based anti-stigma talks. We believe stories can and do change the world, and in Regina alone, we present to over 100 groups a year, including some presentations to nursing students. I've also been married 11 years to someone who's my inspiration and my staunchest supporter. I enjoy jewelry making and Zen doodling. No matter where you are in nursing, people with mental illness will pass through your doors. We break legs, have cancer, need surgery, and will be someone you serve. You can choose how you will react and have a big impact on a person's recovery journey. By choosing to listen to this webinar, you've got a good head start in becoming the change that will transform the system. There are two types of stigma I've faced, what I experience out in the world and what I tell myself internally. Often, they are intertwined. This topic is hard for me to talk about because it is about some of my most painful moments, but I have also found power in sharing my story because in silence there is shame, and shame cannot exist where truth is spoken and shared. Next slide, please. It took me a long time to get diagnosed with bipolar disorder type 2. I was first diagnosed with depression, anxiety, and a nervous breakdown. I was finally diagnosed at age 28. The shame I felt was intense. I felt defective and like it was my fault I was ill. I was so confused and was in so much pain and so disoriented. I was told there would be a 6 to 8 month wait to see a psychiatrist. Next slide. Oh, no, one back. That length of wait told me my suffering was not worthy of immediate attention. The fact I wanted to kill myself wasn't important to the medical establishment. The doctor tried her best, but no one told me if I was in crisis where to get help or mentioned the support groups available. I felt very alone. I wandered onto a website where people talked about their experiences with depression and bipolar disorder. It opened my eyes to the reality that people with treatment could lead regular lives. On that site, I met up with someone in my area who took me to my first peer support meeting. Next slide, please. The peer support group changed my life. Being among peers is the best internal stigma buster. There I realized I did not have to do this journey all by myself. It felt like a second home. Outside that bubble, though, I still felt scared. I did not tell my parents that my world was crumbling, that I had lost yet another job, and that I was periodically suicidal. I felt like a failure. Next slide, please, and could you put up the first poll question? I saw my aunt in the coffee shop one day. She asked me, "How are you?" I burst into tears. Her response was a very quick and awkward, "I'm meeting some friends for coffee and can't talk now, but we'll phone later." That phone call never came. If I had told her I had cancer, I am certain she would have dropped everything to be with me, or at least would have called me that night. Because it was mental illness and she didn't have the words to talk about it, her stigma kept her from calling. And once again, I felt alone and abandoned. I also had a clergy person and friend tell me she didn't believe in mental illness. She said we needed to be with people during their dark night of the soul, and medication was a horrible thing to take that made people zombies. She said this, but didn't volunteer to sit with me at 2 a.m. during my suicidal moments. On the poll, about 85% of people mentioned that they had trouble speaking with someone in mental distress. So it is a problem that many people face. Next slide, please. Perfect. Because it took so long to see a psychiatrist, I lost so much life during that time. I lost a job that was paying $50,000 a year. They swear it was because I didn't write to their standards, but it wasn't a problem until I was open with my diagnosis, and my writing skills have never been a problem in any job since. Perhaps it is true. I know I am not perfect, but it is an awfully big coincidence. Sometimes stigma and discrimination is so infuriating because it's hard to tell where reality lies. Am I being oversensitive, or is more going on? I'm still confused about where the truth lies in this situation.
I continued to deteriorate. I had a psychiatrist tell me my symptoms weren't going to go away. My condition was very hard to treat, and I needed to go home and learn to live with it. I believed that message until I found one day within me a tiny grain of hope. I started to slowly do those things I needed to get well, and through a new psychiatrist, medications got changed, and that really helped a lot. I decided I needed to speak about my experiences. I went to a National Canadian Mental Health Association conference. Their mental illness was talked about openly. It wasn't such a big deal. It just was. I talked to a wonderful lady there and told her a bit of my story and that I wanted to help. She took my name and email. I then started working as a part-time church secretary and did that for about a year before hearing anything more from the lady I talked to. She remembered me though, and when a part-time position came available at CMHA Saskatchewan, she put my name forward. Next thing I knew, I was working as a systems navigator, helping people find the mental health resources they needed. Through my travels as a systems navigator, I learned about the public awareness and stigma-busting talks at the Schizophrenia Society of Saskatchewan. I knew instantly I needed to create my story to be active in the fight against stigma and misinformation. After being a volunteer speaker for a number of months, the coordinator position opened up. Stigma interfered with my confidence. It told me not to reach too high because I may relapse. I took this job against the advice of my psychiatrist, but with the support of my therapist. It's tough some days, but I do it. I do face the odd comment or awkward silence when I tell people where I work. Sometimes they don't know what to say. Next slide, please, and please put up the second poll. My biggest hurdle with stigma is within the medical system. I once went to the ER when I was suicidal and waited 7 hours before seeing the doctor. I was triaged last on the list. When I finally saw the doctor, I was told the on-call psychiatrist was grumpy and would I prefer just to take this medication to see if it helps. At that point, I would have done anything to get rid of the pain, so I took his medication without question. Thankfully, it did help, almost immediately. Had I seen him hours earlier, I would have avoided some of the deepest, most excruciating pain I have ever felt. I have had a kidney stone, gotten into an ER room within minutes, and honestly would prefer that pain to the pain I was in when I was suicidal. A lot of people do not realize just how much suicidal feelings hurt. Sometimes I am denied simple things and patted on the head like a child and told to go home. Again, it is subtle. For example, I've had kidney function issues in the past. I recently asked to do a 24-hour urine test to see exactly where my GFR is at, to see if I needed to do some work on my diet. I know the other test only gives a ballpark figure and can sometimes be inaccurate. This was refused outright. I also mentioned increased fatigue issues and was told, "You are on medications that do this," despite it being an increased issue for me. Her comment as she left the room was, "You are doing really good," said with the sing-songy voice that you use when talking to a 3-year-old. I was so angry I was vibrating as I left the office. Was I overreacting? Was stigma at play? Was I the one being unreasonable? That is what the gremlins in my mind say to me to try and convince me it is my issue. It probably goes without saying I am looking for a new doctor, but that isn't easily done as there are not enough to go around. On the poll, it said that 19% of people have been scared of talking to someone who has a mental illness. What a lot of people don't know is people with mental illness have the same rate of violence as the general population, about 1 in 5,000, but are 2.5 times more likely to become victims of crime. Yet we deal with the onslaught of media that tells society all people with mental illness are violent, and this attitude infiltrates into the medical system. Next slide, please. If it is something simple or unrelated to mental illness, like a pulled shoulder, I will just go to a walk-in clinic and not mention I have bipolar disorder or the drugs associated with it. It is easier than dealing with the stigma. Perhaps not the wisest thing, but I wanted to be honest about the reality of my situation and how I feel. I fear going to the ER for an issue not related to mental illness and being treated poorly. I have heard horror stories from people I know with the lived experience of mental illness of how they were treated. Stigma within the medical system is a huge issue and one that frankly scares me. Next slide, please. I know stigma exists. I know it keeps people from timely treatment. I know it is real. So the way I cope is to be open about it and do something proactive to fight it.
I participate in opportunities like this one and any speaking opportunity to spread the fact that we are just regular people who happen to have an illness. I want to thank the coordinators. The fact that I was invited today to talk is a shift that is worthy of mention. In the past, we were the patients. The mental health professionals and medical professionals knew what was best for us, and that is just how the story went. As I mentioned before, by choosing to listen to this webinar, you've got a good head start in becoming the change that will transform the system. There is hope, and it rests inside each of you. The choices you make matter. They matter dearly to those of us who have mental illness. Next slide, please. Thank you from the bottom of my heart for taking time out of your day to listen to what I have to say. It is truly appreciated.
Thank you, Tanya. So now it is my pleasure to introduce Dr. Judaline Innocent. Judaline is Executive Dean at the School of Health and Community Services at Durham College and also an adjunct professor in the Faculty of Health Sciences at the University of Ontario Institute of Technology. Before joining Durham College, Dr. Innocent was Vice President, Clinical Services and Chief Nursing Officer with Group Health Center. She has more than 20 years of leadership experience in the public and private sectors. Dr. Innocent has taught at several post-secondary institutions in Ontario and is also a designated capacity assessor and conducts mental capacity assessments to determine people's, residents, and clients' mental capacity around their finances and for personal care. So today, Judaline is going to talk to us about the nursing educator perspective on stigma and mental health. Judaline.
Thank you, Jerry. It is such a wonderful pleasure for me to share what I know. Thank you all for joining us. In order to provide context for my presentation, it is important that I define the stigma process. There are three components that are triggers for stigma to occur. First, there is stereotype, which is an unfair belief that certain people with a particular characteristic are the same. It is very common for us to know many different types of stereotypes. For example, one stereotype is people on welfare are lazy, or that people who are depressed can snap out of it. Knowing a stereotype is not wrong, but endorsing it as true is problematic. When we endorse a stereotype and we believe it to be true, we then become predisposed to discriminate. We act on the negative belief and treat the person who is stereotyped differently, whether we do it consciously or not. Why is this important? The next slide will show the stats. However, the literature will tell us that mental health and physical health are fundamentally linked. People living with a serious mental illness are at higher risk of experiencing a wide range of chronic physical conditions. Conversely, people with chronic physical health conditions experience depression, anxiety at twice the rate of the general population. Coexisting mental and physical conditions can diminish quality of life and lead to longer illness duration and worse health outcomes. On this slide, you can see where no chronic physical ailment exists, the likelihood of having a mood disorder is less, whereas those with diabetes or heart disease, cancer, arthritis, or asthma are more likely to have a concurrent mood disorder. With this knowledge, I then ask, do persons with mental illness experience stigma from health professionals? You may use your poll to respond. Okay. So the results show that most of you say yes. Research with people with lived experience say that they are often treated in demeaning manner. They receive negative words or body language that are not appropriate. They feel punished, patronized, humiliated, and they are often the recipient of threats of coercive treatment, and they also suffer from excessive paternalism. Now, the research with health professionals will show that we often hold hostile and blaming attitudes towards consumers, that we see their prognosis as being quite negative, and that problem of awareness, not realizing that we as health professionals carry stigmatizing attitudes and are manifested in our behaviors as well. I'm pretty sure you have likely heard some negative stereotypes. For example, patients with known substance misuse will often be categorized as drug-seeking even when they experience legitimate pain. Patients who attempt suicide, who are kept in an intensive care unit, are often blamed for wasting resources. Patients who experience anxiety related to their physical illness are often called hypochondriacs. Patients who are admitted on a mental health unit are sometimes thought to be incapable. These are some of the stereotypes that we often hear when we work within the health sector. Elderly residents in nursing homes often suffer from both stigma and ageism because they're treated as incapable of making decisions for themselves just on the basis of their age or their diagnosis. Now, people do not wake up in the morning and go to work to do harm. However, sometimes we treat our patients with the best intentions, not knowing that we are infringing on their basic human rights. The rights to make decisions, good and bad, primarily because of paternalism. Now, paternalism is a behavior by an organization or a person which limits a person's liberty or autonomy for what is presumed to be for that person's best interest. As a designated capacity assessor, the test is clear. Regardless of diagnosis, as long as a patient or a resident can demonstrate understanding of their circumstances and an appreciation of the consequences of their decisions or lack of decisions, they are deemed capable. I face challenging scenarios of financial abuse where adult children mismanage their elderly parents' money because the elderly parent is considered quote-unquote incapable. But in the healthcare setting, I see more human rights violations pertaining to personal care decisions, primarily because we healthcare providers sometimes forget that being deemed incapable of making decisions for personal care has 6 dimensions. We have health, safety, nutrition, hygiene, clothing, and shelter. Being incapable in one dimension does not make a patient incapable in all dimensions. Moreover, this is even more challenging if the person has a mental health diagnosis and makes what we deem to be quote-unquote a bad decision. We make bad decisions every day. We have no right to prevent others from making bad decisions if their decision-making abilities are intact. As we know, the consequences of stigmatizing may result in negative health outcomes, depression, despair, financial or material exploitation, and human rights violations. Tanya certainly demonstrated that in her story, which was very, very, very heartfelt. As educators, we need to have very strong understanding of stigma and its negative effects. We need to recognize structural stigma in our clinical setting with policies and procedures that are unfair.
We need to educate our students on what to watch for and to advocate for change. These are some of the responsibilities that we bear in terms of making sure that our students are prepared for their clinical setting. For the students need to be aware of stigma and be very aware of their own misconceptions and prejudices. They need to be vigilant by having their radars up when they hear stereotypical statements being made. They need to reflect on their own beliefs and views and how their belief may enhance or hinder patient care. And they need to take action by speaking up against stigmatizing their clients, patients they serve, and by being very careful with what they watch and how they intervene. So this is pretty much my presentation. My last word will be that as educators, it is important for us to lead by example. We address stigma at the root where it begins, which is often in the language that we use to describe particular groups of individuals, and condone negative stereotypes by not correcting what we hear. We need to be vigilant to break the stigma process, which involves stereotype, prejudice, and discrimination. And I really would encourage us as educators to make sure that we do access the resources that are made available to us through the Mental Health Commission of Canada. Thank you very much for your time.
Thank you very much, Judaline, and thank you again to our speakers. So we have a few minutes left, and I would invite you now to submit questions that you have by typing into the Q&A pod. And as I told you earlier, the questions, your name is not connected to them, so if you have a question to ask, you can ask it anonymously. You can ask a general question to all of our speakers, or if you have a particular question for a speaker, please do that as well.
I think, Jerry, we had a question that was sent in from one of our audience members that was for Romy. And we wanted, it says you talk about how speakers telling their own stories can reduce stigma. Do all stories work?
Oh, such an important question, and one that, again, at the beginning, we were surprised with. We evaluated so many programs, and some of them worked, and the odd one, it seemed like stigma was increased even with speakers telling their stories. So we needed to really figure out, okay, what is it about a speaker's story that is going to reduce stigma? And we realized that the speaker must be in a place of recovery themselves. If they are in that, heightened stress and place of need that I referred to, that doctors see, for example, in their offices, or nurses see in an ER, then those are the kind of stories that, in the end, you can see in an audience, and I've kind of watched it with some of them, that people are just enwrapped by the story. They're so pulled in by it, but at the same time, one of the aspects that we measure is something called social acceptance, or the flip side of that, social distance. And you can imagine how, if there is someone and they seem, to really be in a heightened state of not being well, that people in the audience might be sort of pushing themselves away from that person speaking. And that's what happened. And so it's very, very important then that speakers are like Tanya, that they speak when they're in a place of recovery and can model recovery, and they're the kind of people that, if they're sitting in the audience or if they're sitting on, in a panel, nobody would know, okay, oh, that's the person, So yeah, we were surprised by that.
Thanks, Romy. We have another question here, and maybe I'll direct this one to Tanya. It says, where can we get more knowledge or information about how to speak and interact with individuals who experience, who live with mental health problems besides school? So what resources do you know of, Tanya?
Well, I think connecting into your local schizophrenia society is a good place to start, as well as Canadian Mental Health Association. Most knowledge is firsthand. The more interaction you can get with people who are actually experiencing mental illness, the more you'll know what to say and do. It's a learning curve. Expect yourself to have some missteps along the way, and that's okay. The biggest thing is to not be silent, to reach out and make the effort, because that will be so appreciated by the people that you serve and the people that you know in your own life.
Thanks, Tanya. We have another question here, and Judeline, I'll ask you to respond first, please. What would be your advice to healthcare professionals and to students and to educators about what they do if they observe stigmatizing behaviors or attitudes in a healthcare setting?
That is a very, very important question, and I think what is most important in terms of responding to this question is to intervene, because the cycle of stigma has to be broken, and one way we can actually break it is by stopping the conversation right at the stereotype. Now, I did also want to mention that Tanya, in her presentation, spoke about what we call self-stigma. There are three different types of stigma. We have self-stigma, which is the belief in the stereotype that the public has for you. For example, if the public sees you as being incapable, and you've heard it so many times over and over and over again, you as the person who is living with your lived experience with a mental health challenge, then you start believing in the stereotype that they have for you. The other one is courtesy stigma, which is often felt by health service providers who are standing up and speaking out against stigma. When you do speak out for stigma and you say, this is not an appropriate language, and this is how we start treating our patients unfavorably, is when we start talking like this, then oftentimes that health service professional may experience stigma because they're actually speaking out. And it's important for us to have a sense as to, okay, how will I respond, and how will I feel, and how do I maintain my integrity despite not having full support from my colleagues? And the last stigma is called structural stigma, which is where the organization itself has stigmatizing procedures and policies that are not conducive to an environment where we treat our patients with respect. And there again, as educators, we need to be able to speak to those and influence change by actually addressing the situation and presenting it to the leaders who may not see the stigmatizing nature of certain policies and procedures.
Thanks, Judeline. Romy or Tanya, would you add anything?
I think it was covered fairly well there. I concur with what was said, definitely.
Great.
I thought it was really good too.
We have another question, and I'm just going to put it out to all of the speakers. And the question is about the prevalence of lived experience of mental health problems among healthcare providers. So we know that healthcare providers are human beings, and that we experience many of the stresses and strains that other people do. What do you know, Romy, about the prevalence of mental health problems among healthcare providers?
I know that there are people that have researched that. Certainly we know that, many people with within the healthcare profession, they would be the same as in the public. And we say that, 1 in 5 in a year experience a mental health problem, so we would assume that it would be the same among healthcare providers. That also, though, is an assumption. We have not done research into that area specifically.
Mm-hmm.
I think the part, this is Judeline answering the question as well, the part that complicates matters for health professionals is truly the self-stigma. In that stigma, when you are in the healthcare field, there is significant stigma associated with being able to have that inner strength to speak up and say that this is what you're experiencing and these are the resources that you need, primarily because the fear of stigma is very, very alive within health service providers. So sometimes it makes it extremely challenging for nurses, physicians, or other health allied professionals to come forward and express their despair and their need because they're afraid of being stigmatized as well.
Yeah. I have some friends with lived experience that do work in the healthcare field, and I know from talking with them, there is this great fear that if I disclose that I have a mental illness, I'm never going to get another job. Mm-hmm. You know, so for them the fear, and I think it's an accurate fear sometimes, is that their advancement in the medical field will be thwarted if people know that they have a mental illness.
Mm-hmm. Well, thank you all. I see that our time is quickly running out here, but before we sign off, I would like to hear some final thoughts from the presenters. And Romy, I wonder if you would start again, please.
Okay. Well, we are so excited, one might say, by the fact that we have identified programs for these different healthcare audiences, healthcare provider audiences, and really now the challenge is, how do we get these programs adopted and known, and certainly any assistance that anybody can provide to us as well would be great, by talking about the fact that, oh, we know the Mental Health Commission has evaluated programs that will make a difference for patients, will make healthcare professionals feel a real heightened sense of confidence and provide them with skills. And so, you know, we hope that you'll help us spread the message a little bit as well, and get in touch if you have any other questions.
Thanks, Romy. Tanya, your final thoughts.
I really believe the system can reach a state of recovery-oriented practices, and we really need the help of all of you listening today. The Mental Health Commission of Canada boldly states that recovery for the individual should be expected. I believe recovery-oriented, person-centered practices should be expected within all levels of our health system. We need champions, people to stand up and say with confidence, we can change this. Your leadership can and will change the system. So thank you.
Thanks so much. Judeline, your final thoughts.
Thank you. The literature will tell us that education alone does not change attitudes. Obviously, as health service providers, we have tremendous knowledge. Very much like Romy says, it is important to access resources because we do know that there are issues. We need to become more aware in terms of our environment and what we hear and how we intervene, but we also need to have open dialogue. We need to talk about it so that we can remove the discomfort that we feel by talking about it. And then that way we'll be making the right step in the right direction to really reduce stigma and the pain that we cause by stigmatizing the patients who trust in us to provide them with the best care.
Thank you so much. Well, this is bringing our webinar to an end, and I really would like to say thank you again to our speakers, Romy Christie, Tanya Kondo, and Judeline Innocent. Thank you, too, to all of our participants, and to Margot and Sharada at Kazan for helping to make this webinar possible. I would also invite all of the participants to take a few minutes to give us some feedback, to complete the evaluation survey. So all of you, or I presume many of you, are educators, and you know the importance of feedback in helping to improve future webinars, or to give us some ideas also for future webinars. So please, before you get on with your busy day, or at some time in the next few days, if you wouldn't mind filling out the evaluation, we would really appreciate that. Margot, do you have any final words before we sign off?
Thank you so much, Jerry, and thank you to all of the panelists. What the participants probably don't realize was that 30 seconds before we went live, Romy lost contact with Adobe Connect, so she's been presenting blind, and I think she did a fabulous job. Tanya, thank you so much for your presentation. You're a very brave woman, and thank you again to Judeline for bringing the science into the presentation. Each of the participants will receive an email as well with a link to the evaluation survey, as well as an article that Romy wanted to share with all of you related to this topic. And we'll also send that link to you to all join the interest group if you would like to participate in future endeavors from the Kazan Mental Health Educator Interest Group. Thank you very much to all of you.
Thank you. Bye, everyone.
Bye. Thank you.
Bye.
Yeah.